and welcome to today's webinar, Early Detection and Intervention for Suicide Prevention, Experiences of Crisis Helplines in the Americas. My name is Mark Signor. I'm Associate Professor of Psychiatry at the University of Toronto and the Americas Lead for the International Association for Suicide Prevention's Partnerships for Life initiative. It is my great pleasure to welcome everyone joining us via Zoom. A special thank you to both the Pan American Health Organization and the University of Toronto for co-hosting this webinar, and to our wonderful presenters. I also want to acknowledge and thank the Chief of the Mental Health and Substance Use Unit at PAHO, Dr. Renato Oliveira e Souza, his colleague Amy Tausch, and my research coordinator, Daniel Sanchez Morales, for organizing this webinar. A few reminders. I would like to remind you that simultaneous interpretation is available in English and Spanish. To activate translation, click on the globe icon on the bottom of your screen and choose your preferred language. This is the second in a series of webinars jointly organized by PAHO and the University of Toronto, aimed at educating our community about suicide and how it can be prevented. Please look out for more information on the next two webinars, which will take place in the first half of 2025. We have evidence-based interventions, which when properly implemented have been shown to reduce suicide rates. In particular, there are 4 key interventions outlined by the World Health Organization's Live Life Implementation Guide for Suicide Prevention in countries. Each of the first 4 webinars that we are organizing jointly will focus on one of these interventions. Our first webinar, which we held on September 10th, World Suicide Prevention Day, focused on changing the narrative and responsible media reporting. Today, we turn to the crucial issue of early detection and intervention, and specifically the important role of crisis helplines across our region of the Americas. We have 3 outstanding speakers. I can tell you this from personal experience. I have collaborated with all of them. We're really in for a treat today, and they will help us increase our knowledge about helplines. Following all of the presentations, we will have time for questions and answers of all of the presenters. We encourage you to use the Q&A, so please use that Q&A box at the bottom of Zoom, not the chat box for questions, to share any questions. You can do that at any time, but we'll save them until the end. And now it's my pleasure to introduce our first presenter, Dr. Richard McKeon. Dr. McKeon is currently Senior Advisor at the United States Substance Abuse and Mental Health Services Administration, 988 and Crisis Office, after serving for 12 years as Chief of the Suicide Prevention Branch in the Center for Mental Health Services. He served on the National Action Alliance for Suicide Prevention Task Force that revised the 2012 National Strategy for Suicide Prevention, and the U.S. Department of Health and Human Services Project Management Team coordinating the 2024 revision of the U.S. National Strategy for Suicide Prevention. In 2023, he was awarded the American Association for Suicidology Dublin Award for Lifetime Achievement in Suicide Prevention. It's so wonderful to have you with us today, Richard, and I'll turn it over to you.
Thank you so much, Mark. It's a pleasure to be here today. And I will be trying over the next 20 minutes to give you an overview regarding hotline services in the United States, particularly 988. So this will be past, present, and future. As part of that, I will explain some of the links between our hotline work and the recently released United States 2024 National Strategy for Suicide Prevention. You can go on to the next slide. So 988 has been a major innovation for us in the United States. But before I go into detail around 988, let me just give you an idea of the past development that led to where we are now in the US. In 2005, we launched the National Suicide Prevention Lifeline as a network of over 200 crisis call centers across the United States. This network gradually built over time to include in 2007 a link to the Veterans Crisis Line, the addition of a Spanish language subnetwork for callers. And then in 2013, a chat service was added. And all of this was influenced by a series of SAMHSA-funded evaluations. This was some of the first evidence that showed that hotlines could be effective in reducing suicidal ideation among callers, and also in demonstrating that people at high risk would, in fact, call hotlines because there was a belief previously that people at risk would not call. That has certainly been disproved. And our evaluations also led to significant uh, program development initiatives, including the development of standards for suicide risk assessment on the line, so that everyone who calls is asked three prompt questions, and guidelines for callers at imminent risk. So I'm not going to have time to go into all of the evaluations data in detail, but I did want to make sure that people were aware of um, these important studies, and we can certainly share more about them later on. And then as we talk about the role of hotlines in terms of early detection, one key issue that we wanted to mention is that when we launched 988, we had in some ways, subtle but also important rebranding. Previously, it was called the National Suicide Prevention Lifeline. It has now been rebranded as the 988 Suicide and Behavioral Health Crisis Lifeline. The idea was that we didn't want to inadvertently communicate that someone had to be suicidal in order to call. Because we want people to call as soon as possible. Um, so, for example, if somebody was feeling depressed or depressed and hopeless, we certainly would not want to communicate that they needed to wait until they're thinking about suicide in order to call. We would want them um, to call early on in the development of their emotional distress. And so, emotional distress in and of itself is an important reason to call the lifeline, as well as for third parties, family members, or friends who may be concerned about someone else, um, to make such a call. Another example would be that um, when you think about other behavioral health crises, all of which have heightened risk for suicide, let's say someone experiencing substance use issues or psychosis. Um, Again, we do not want to wait till somebody is suicidal for them to be able to reach out to help. We want them to reach out earlier. So that was the reason for the rebranding. So where have we come since the launch of 988? In July 2022 was when um, both by law, a law was passed by Congress and signed into law by President Trump, the National Suicide Hotline Designation Act. Um, and it was also ordered by the Federal Communications Commission that by July 2022, every cell phone, every landline, every voice over internet device in the United States needed to make 988 operational. In addition, the FCC also ordered that texting to 988 needed to be made operational by that same date. So the full launch of 988 took place in July of 2022. So we are 2 years and a few months past that date. In the first 2 years, our hope that a three-digit number would be easier to remember and would lead more people to call for help was shown to be accurate. Over 10 million calls, chats, and texts were answered in that 2 year period. And of course, it's higher now since July of 24. That included nearly 6 million calls answered, nearly 1.7 million texts answered, and 1.3 million chats answered. We also expanded access to care through specialty services. So while we had had a Spanish language sub network for people who called in going back through to 2007, we added Spanish language text and chat in the period since 2022. We also added a press 3 option for LGBTQI plus youth that again connected to a subnetwork of those with specialized experience and training in working with this high risk population. An additional expanded access to care was a video phone service that was launched, which allowed for people to receive help via American Sign Language. So these were all important expanded access to care. If you could move on to the next slide, that would be great. In addition to the work of the federal government, in terms of oversight and significantly increased funding for 988, many states have become actively engaged regarding 988. And while every state is engaged, numerous states have taken additional options. 10 states have instituted a 988 cell phone fee, which was allowed but not mandated through the National Suicide Hotline Designation Act. 9 created an advisory board. 14 established a trust fund. 8 strengthened crisis care insurance coverage. 7 implemented studies to look at financing or gaps in the crisis system. And 30 passed appropriations for at least one of the core crisis care services. SAMHSA's National Guidelines for Behavioral Health Crisis Care has identified 3 core services: the 988 hotline, mobile crisis, and crisis stabilization units. We can move on to the next slide. Obviously, there are still challenges. While we are very heartened by the initial launch in the first 2 years and the engagement of states and communities across the country, there are certainly ongoing challenges. Workforce shortages are particularly important because crisis services need to be 24/7. So especially at night, that can be a challenge to recruit during that midnight to 8 a.m. Time block. These can be very high stress positions, and that can lead to turnover. Sometimes in different states, there may be scope of practice limitations. There are geographic challenges, for example, for mobile crisis teams. A mobile crisis team going to a remote rural area will take more time than in an urban area. While has been increased financial resources, including a 5% crisis block grant for SAMHSA's mental block grant program, there are still financial challenges, particularly as the need for increased capacity continues to grow. The provider training needs that not every mental health professional receives intensive training around crisis services. And then connecting crisis care, the interconnection between 988 mobile crisis stabilization, and outpatient services. We know that the period after a call can be a period of continuing risk. Suicide risk does not completely disappear, even if it's lessened on the call. So that connection during episodes of care is particularly important. Next slide. It's for this reason that SAMHSA has developed National Crisis Care Guidelines. We are currently in the process of building on these guidelines and establishing standards for national crisis care. We expect that will be going out for public comment in the very near future. And again, as this slide just indicates, what we regard as the core elements of the crisis system: regional or statewide crisis call centers, mobile crisis receiving and stabilization, and then essential crisis care principles and practices. Next slide. So this current year and going into next year, we have had a number of different goals. One that is in the process of being implemented currently for the majority of Americans is call routing by geo-routing. Previously, all calls uh, um, were sent based on the person's area code. Now, lots of people now move, so they no longer live in the area where their phone's area code was. That is in the process of being changed. The three major telecom companies, two have already made this, the third is in process. And there's now a Federal Communications Commission order for all carriers to utilize geo routing, which means that the cell tower that the cell phone call goes through will be used to direct it. Not the kind of pinpoint location that 911 has, but it will allow us to be much more sure that local calls will be answered by local centers. Continued improvement of operational response, working on improved transparency of 988 outcomes. Vibrant, our administrator of 988, recently released a white paper on imminent risk callers. That's an important step in that direction. We're working on standardization of contacts, continued expansion of local chat and text, improving our data collection, and continuing to raise awareness and building trust in 988. Next slide. We are working on extensive research and evaluation efforts, including partnering with external researchers. We have begun a 5-year comprehensive evaluation plan that, in my judgment, is one of the most ambitious efforts to study crisis services in the United States that's ever been undertaken, and trying to provide a cohesive national picture on progress in both access to crisis services, along with the impact on both individual and community systems. Next slide. Another important area that we are working on is coordination between 988 and 911 emergency response systems. We think there are many calls that go to 911 that can be handled through 988, potentially reducing unnecessary police involvement. On the other hand, suicide attempts in progress would typically need to be going to 911. So we are working in a number of areas on this, and the National Emergency Number Association will be putting out some guidelines in the very near future regarding 988 and 911 interoperability. Next slide. We have done formative research to find out how different high-risk populations, what messages reach them, and who would be the messengers who they would trust to receive information regarding 988. We looked at groups such as those with lived experience with suicidal ideation or attempts. We also uh, Black youth, uh, older rural men, American Indian, Alaska Natives, for example. So those are some examples of groups that we have tried to do a deeper dive into. Next slide. We do have some paid marketing out there, but we have really been gratified by the extent to which many groups and states have promoted 988. Next slide. And this shows you so some of the messaging that has gone out. This past September, we had the first 988 day, and people all across the country helped in putting out information about 988. It even turned up as a Jeopardy question. So, at any rate, we have been really glad for the way people all across the country have joined in this effort, letting people know about 988. Next slide. We have started a 988 Training and Technical Assistance Center. Um, and you can use the QR code there to get more information. In the interest of time, I'm not going to go into great detail around it, but this is open to people, organizations, states, communities to reach out for help. Next slide. I also want to mention, and I'll go through this relatively briefly so I don't eat up more than my allotted time. Um, but 988 is an important part of the new US 2024 National Strategy for Suicide Prevention. This is the third iteration of the national strategy. The second was in 2012. At that time, we had no idea there would be a 988. So we wanted to make sure we explicitly incorporated it into the new national strategy. Next slide. The new national strategy has four strategic directions: community-based suicide prevention, treatment and crisis services, surveillance, quality improvement and research, and health equity in suicide prevention. 988 falls under strategic direction 2 on treatment and crisis services. Next slide. Okay, next slide. So goal 8 in strategic direction 2 is focused on treatment, implementing effective suicide prevention services as a core component of healthcare. And connecting crisis services to healthcare is an important part of that. I am not going to read to you all of the objectives, but wanting you to be able to see that. The national strategy is available online for people to look at in terms of all the specifics. Next slide. And these are the rest of the objectives that are in goal 8 around making suicide prevention a core component of healthcare. You can go on to the next one. So goal 9 is the one that focuses specifically on crisis services to improve the quality and accessibility of crisis care services across all communities. That's the focus of SAMHSA's national guideline. Some of the objectives highlight the importance of quality improvement, of collaboration between 988 and 911, the expansion of mobile crisis teams and diversion programs from 911, uh, timely access to assessment, intervention, lethal means safety counseling, and follow-up are all important components around this. And that is the end of that part of the objectives. But one thing that was unique when we released the U.S. national strategy, was we included a federal action plan for the first time. Over 200 actions that were committed to by various federal agencies to implement over the next 3 years. Next slide. Next slide. And so this is just a sampling of the ones that have been committed to that have that relate to crisis services, evaluating the quality and accessibility of services, identifying gaps that need to be addressed, developing common data elements. Next slide. Assuring that there is effective continuum of crisis response services, and making sure there's reimbursement from Medicaid and from the Children's Health Insurance Program. Reducing suicide risk through safety planning. Next slide. Monitoring 988 contacts, particularly suicide attempts in progress, and both voluntary and involuntary emergency interventions. So when people are at an imminent risk, which often we are able to decrease on the phone without requiring emergency intervention, but sometimes it is required, and to evaluate the outcomes. Developing a mobile crisis locator, a 988 911 case book, identifying when 911 versus 988 should be contacted, increasing the number of 911 diversion programs. These are all examples, things that are part of the federal action plan. Next slide. The development of community crisis response plans by the Indian Health Service, in the Veterans Crisis Line, the ongoing work on reducing access to lethal means. These are other examples, and all of these federal action plan items are also available online along with the national strategy in a companion document. Next slide. Looking at crisis services among older adults, and those who are duly diagnosed with intellectual and developmental disabilities, are other areas that are part of the federal action plan. Next slide. Military cultural competency training for both when veterans and active duty military or families contact us, cross-system collaboration to improve public safety responses. And again, and you can see that various federal departments here that have been engaged in these action items: Department of Defense, Department of Justice, that's or the acronym for DoD and DOJ. Next slide. And then finally, we are working together with the National Action Alliance for Suicide Prevention on a plan for monitoring and evaluating the national strategy. We have actually had consultations with the Australians and with those in Ireland, who have also been working in this very same area, so that we can, on an ongoing basis, know, are the activities that are part of the national strategy being implemented, first off, and if they are being implemented, what is the impact that they are having? Next slide. So at any rate, that is the last one from me. Mark, I think we're saving questions till the end. Is that right?
Yes, thank you so much, Richard, for really, just it's extraordinary what you've done and for presenting it in such a clear and crisp way. For the interest of time, thank you to everybody who's put questions in the Q&A. We will get to them at the end, but just for now, I'm going to turn it over to our next presenter, Dr. Alison Crawford. Dr. Crawford is a psychiatrist at the Center for Addiction and Mental Health here in Toronto. For people who don't know, this is the biggest mental health teaching hospital in Canada, and the chief medical officer of our version of 988, which has now been around for about a year. She's also medical director of psychiatry outreach and virtual care at CAMH, and professor in the departments of psychiatry and Dalla Lana School of Public Health at the University of Toronto. Alison is a scientific advisor to the Sustainable Development Working Group of the Arctic Council and leads the University of Toronto's membership in the U-Arctic. Her research focuses on ensuring access to mental health, suicide prevention and equity, and cultural safety and digital health. Alison, it's such a pleasure to have you with us. Please go ahead.
Thank you so much, Mark. And thanks so much, Richard. I think just by accident, we've ended up organized by population, population size. So Richard's speaking about the US. I'm going to talk about Canada, and then Dr. Siebert will talk about Costa Rica. And I hope one message there is that this kind of intervention, a crisis line, suicide prevention helpline, is feasible across a different contexts and at different scales. I already noticed that there's a mistake in our title. We are 988 Suicide Crisis Helpline, and that's the helpline in Canada. And I'll talk a little bit about scope, because that's maybe one difference from the US. And I was very jealous, Richard, that that 988 was mentioned on Jeopardy. I think our team has a new goal, and that might speak to. So what I've done is, with a little bit of a gamified approach, I have given the top 10. I'm going to organize this by the top 10 things that helped our team implement 988 in Canada over a very tough time course, and over the course of about a year. So 988, some things are very similar to the US. So it was, we implemented about a year later. So we really benefited and benefited from Richard and his colleagues, from their advice and expertise, and also in the political landscape. So similarly, easy to remember number, 3 digits. Ours is available in English and French, which are our 2 national languages. Also 24/7 availability across Canada by phone and text. I'll say something here also about the scope. So we really have narrowed in, at least for this stage of our implementation, on suicide prevention. We recognize, we too would like people to call when they're in distress, because we know people in distress have a higher risk of suicide, but we really promote the line in relation to suicide prevention. Here are our numbers so far. So this is over the first year, but it's actually about 9 months of service. So we get approximately 1,000 interactions per day by call or text. And over, if these numbers track, that will be approximately just below 350,000 interactions within the first year. It's not quite 50-50 in terms of call and text, but our text rates are growing. And you can see our answer rate there. We've found that this actually is a very important metric to people staying on the line, and I'll talk about that. So what has helped us? Here we go. Number 10, getting a commitment. This was very critical and involved kind of leadership and change management across, it was multi-sectoral, and in particular political support. So you see here, we got the funding. So the Center for Addiction and Mental Health is, I guess, what you would call the administrative partner for making comparisons with the US. We received money to start the Canada Suicide Prevention Service, building on some pre-existing services in Canada in 2020. But it was really a motion at the end of that year in the House of Commons that passed to a motion for a 3-digit number, and then it went through our federal communications and radio telecommunications department, and they do public proceedings, and that happened over the course of 2022. But getting that commitment, having that leadership was incredibly important. And similarly, our National Suicide Prevention Action Plan, which just launched, so this is our federal public health agency of Canada, drive this action plan, and 988 is a core component. You can see that there. We're a core component of the plan. So getting that commitment and having all of these connections. Number 9, adopting an implementation mindset. This has been really important in kind of organizing our approach, in helping us set targets. We used the RE-AIM framework, which is reach, effectiveness, adoption, implementation, and maintenance. I should also have said each of these top 10 could be its own 20-minute talk. So I am really happy if anyone wants to contact us after this to talk in more detail and to make any resources available. But really having this mindset of like using implementation science to have the right reach, and then also to have our eye, of course, on effectiveness. And I'll talk about equity in a moment. But one thing that we added to the REAIM framework is a real focus and on all of these levels on equity. So on equity, inclusion, on accessibility, throughout everything that we do. And here, actually, we just published this, which was on the first 6 months implementation outcomes, early implementation outcomes for the first 6 months of service. Number 8, I mean, this could really be number 1, but because it echoes throughout everything. Partner for success. This is not, although CAMH has worked very closely with the Public Health Agency, it's really the service itself is a network of partners. We have just under 40 partners that deliver the service, but our partnerships are also multi-sectoral, and I think will increase over time. It's really important to kind of get that buy-in at all levels of government, of healthcare, even of education. We've started to reach out. So I think partnership is incredibly important. And here I get also the chance just to acknowledge I'm presenting today, but this is the work of many people on the team who do an incredible job. We work very collaboratively as a team at CAMH. And those partnerships have really helped us to bring to life one of our principles, which is community-based suicide prevention support. So because we have partners across the country, the actual service is a network. It's somewhat similar to the US with some differences that we can maybe talk about. We also have some national providers like Kids Help Phone and Hope for Wellness, which provide service to First Nations, Inuit, and Métis service users. Number 7, this is a bit of a busy slide, so I'll pause here for a sec, but creating a learning health system. So having a quality framework that is very live and very active. So we are continuously collecting quantitative data, qualitative data, volumetric data, the volumes on the service, and constantly holding those against these core areas of quality. And you'll see at the center of our quality framework is a service user. You belong here. And that means that you can access 988 so that there's awareness across Canada. So we look at marketing research for some of those questions, that it can be reached anywhere in Canada, and that it's answered in a timely way, so volumetric targets and data, that 988, that people feel included there, so that it is a service that works for a diverse groups who may have different needs, that there's trust there, and that also there's diversity amongst our responders as well, so that the people actually responding to and delivering the service match the great diversity in our population. Safety, that you're safe, and that means, of course, suicide safety, but also trauma-informed and culturally safe care, and that responders also feel that, and that organizations have a responsibility to promote that and create that sense of safety. And of course, that it's effective. We know that crisis lines in general, they do reduce distress. They have good short-term outcomes in terms of suicide prevention. We want to make sure that we're delivering an effective service. But also, I think there's lots of research that still needs to be done on the longer-term impacts of crisis lines. And actually, here's an example of that. So volumetric data, here you'll see in the graph on the left, across the course of the day, you see that the calls, as we might expect, the volume goes down between 1 and 4 a.m., but the wait time goes up markedly. And what we discovered is that the call abandonment rate also goes up during that time. So then that's obviously decreased access. If people are hanging up, and that's just shown in more detail on the right, when the wait time is over a minute, we go from a 6% abandonment rate all the way up to 45%. So it's these kinds of putting this data against that quality framework that allow us to make changes to the service. It's hidden on my screen. One sec. Number 6, centering access, inclusion, and equity. This is a live artist drawing from our Equity Collaborative, which is a community of practice to really look at enhancing equity across the crisis line sector in Canada. We've done, I would say this is the area we focus the most as well in terms of research. We've done lots of community outreach to different groups. We've looked at technology. So we also have an IVR so that people who are First Nations, Inuit, or Métis, or people who are under 18 can get a specific service. We're looking at the effectiveness and the impact of that. But equity is huge. And we're also implementing a post-call survey where we will have data stratified by a number of socio-demographic variables as well to help try to understand whether the service is immediately meeting people's needs based on equity. Number 5, this actually has been one of my favorites and a bit of a surprise as to how impactful this has been. And I noticed Richard had a slide about communication. So we have a communications program. Helen Davies is our manager of communications, and they have done amazing evidence-based work at figuring out what kind of marketing to do, even very upfront in terms of the branding. So I wouldn't have thought crisis line and branding were a thing, but they really are. And in fact, it's a bit funny. I didn't mean to wear yellow today, but yellow is one of our colors. Paho's got the yellow. So that even down to the choice of color, of name, making sure that it resonates with people and that it feels safe for people. What you can see on here, on the left-hand side is a resource that we've developed called We Can Talk About Suicide, and it's really to support people to have conversations with people in their lives about emotional distress and suicide prevention. Because we know that stigma, our communications and our availability, our marketing directly contribute to, we hope, to reducing stigma around reaching out. Standardizing the intervention. That too has been very important. We really want to make sure that the evidence that emerges in this field is immediately implemented, and that this is an evidence-based approach. And this isn't meant to make the interactions and the collaboration between service users and responders rigid or scripted, but it's really to say these are the core components that need to happen, and to make sure that the training is aligned with that. In particular, that people are being explicitly asked about suicidality, which prior to this was only happening about 50% of the time. We're also doing work around training for that. We're working with the Health Services Organization. There were no Canadian crisis line standards. We're just getting started on this, and it's very exciting. We developed a competency framework for responders and supervisors, but this will actually create a comprehensive standard for crisis lines in Canada. Number 3, we're getting to the end, support a diverse and flourishing workforce. So we have done surveys of our responders. We've looked at well-being. We've looked at training. The image on the right is a graphic for the competency framework that we developed so that people can self-assess their own competencies, and then we provide appropriate training. Making sure we're also realizing we do work on crisis supports for first responders, and it's made me realize that we're creating another first responder workforce, and we have to make sure that they're also properly supported, not just trained, but also properly supported, and that their well-being is looked after. Number 2, engage the people who will use the service. So we have a number of working groups, and we have multiple ways for people with lived and living experience. Diverse people with lived and living experience can be involved in every aspect of our service. They've been involved from the beginning and are meaningfully involved. They're remunerated for their time, and have been really pivotal in ensuring that this service meets people's needs. And number 1, and this has always been important, and true since the second we started this, and I know it's also a key part of this sector, that it's an area that's really driven by values, and that's helped us make a lot of key decisions. I've talked about some of these. So being community engaged informed our model profoundly. Equity, which I've talked about, being a learning health system. So, being responsive to evidence, being culturally safe and trauma informed, the importance of belonging and of compassion. And I am constantly struck by that. And I would even hazard to say love. Like this, the people that run this service, work in this service, are so it matters to them to create cohesive communities where people feel a sense of belonging and value, and where they inspire hope, especially when people are struggling. And I don't think we can't always measure that, but I think it really pervades everything that we do. And so I've left it with a quote from from someone who used our service. And I think we're fortunate that we sometimes hear back from people about how impactful the service has been. I'll leave it there. Thank you.
Thank you so much, Dr. Crawford. I'm just always reminded that people don't emote to statistics and graphs. And so I really like that you ended with a quote. It just shows how important this is. And if you kind of expand this out to all the different people that the service is now helping, it's just something unbelievable. So huge congratulations and thank you for the talk. And let me just now introduce our third speaker, Dr. Elizabeth Seward. Dr. Seward is a clinical psychologist working in private practice. She has been an external consultant for a variety of projects related to the Costa Rican Ministry of Health. She's been responsible for the coordination and the implementation of community suicide prevention programs in local government, public universities, and private institutions. She has given workshops in conjunction with the Costa Rican Board of Psychology on suicide prevention and treatment for healthcare professionals. She has worked as an external consultant for the United Nations Refugee Department, ACNUR, in Costa Rica. She is currently pursuing a master's degree in human rights. And thank you so much for being here, Elizabeth. I will turn it over to you.
A ustedes las gracias. Yo voy a
Thank you
hablar,
for having me.
mi presentación va a ser en español.
I will
Pues
give my
vamos a hacer un
presentation in
cambio de
Spanish, so let's
idioma.
switch languages.
Quisiera agradecer la
I would like
oportunidad
to
de
thank
compartir con
this
ustedes
opportunity to be sharing with
que ha
you
estado
now
haciendo Costa Rica,
a work
país
that's being conducted in
pequeño
Costa
de
Rica, a small
5
Central
millones de
American
personas,
country. It's
pero que ha
about
tenido
5 million
gran
people
compromiso
overall
con la
in our
prevención del
country, but the
suicidio
country has been
desde
very
hace
much committed
muchísimos
to
años, mucho
suicide
antes
prevention for
del
many years now,
2014,
long
cuando la
before
OMS hace un
2014
llamado
when the WHO
mundial sobre el
called
tema
on
del
the entire
suicidio.
world
Yo les voy a
to tackle
presentar
suicide.
el trabajo que se hizo,
I
una
will
línea
show you an
de
overview
crisis a
of
nivel
what we
nacional
did
que
here.
se
It
llama el
involves
despacho de apoyo
a
psicológico,
helpline,
DAP.
and in Spanish, it's
Esta línea de crisis fue la
DAP, DAP,
colaboración
Psychological
de 3
Support
instancias en
Office,
Costa Rica.
basically. This involved 3 instances in Costa
El
Rica.
Ministerio de Salud,
First, the
el
Association
Sistema
of
de
Psychology
Emergencias
Professionals in Costa Rica, the
911.
Ministry of Health,
Es
and
una línea gratuita en todo el territorio
the emergency
nacional.
system
Eso fue
911. This is a free
porque se
toll-free
montó
line across the entire territory.
dentro de la estructura que ya tenemos de
And
emergencias
this is so
911.
because it was added on
fue
the
impulsado por la
existing
pandemia del
structure at the time,
2020,
the
y el
911. So this
objetivo era
DAP
atender las solicitudes de apoyo psicológico,
sought
haciendo
to
una
address
diferenciación de las
psychological
llamadas que
support
llegaban a
requests by
911
offering
de
support
emergencias
to all
físicas
those incoming
de
calls to
emergencias de
911
más índole emocional.
and address the ones that
El
had to do with
objetivo
emotional
general
nature.
de la
The
línea
overall
era
goal of
crear
this
una
helpline
herramienta
was to
estratégica
create a
prioritaria
strategic and
para el
priority
apoyo
tool
psicológico
to
en
offer
incidentes
psychological
relacionados
support,
a
psychology
síntomas
support in those
emocionales,
incidents that were
de
connected
forma
with emotional
inmediata
symptoms
brinda a las
in a
personas
way that
usuarias
was
de los
immediate and
servicios de
thus
salud
offer
los
users
recursos de
of these
apoyo
healthcare
para enfrentar
services
la
the right
situación
support
y a su vez
resources to
permite la
face the situation.
activación
And
de
by doing
otros
this,
respondedores
enable the
interinstitucionales
action
que
of
brindan
other
apoyo
institutional
profesional
responders
calificado
who
para
can
el
also
siguiente
offer
el
their
seguimiento
qualified professional
especializado en
support
esos casos.
to conduct specialized follow-up of these cases. As you can see, there were several specific goals that the country was trying to address or cover in the face of these needs from the population. The specific characteristics or the most prominent characteristics of the DAP is that initially it was not intended exclusively as a suicide lifeline. And I think this was very new in the sense that many times someone may have suicidal thoughts, but they will not manifest this so clearly. So the fact that a person can call because they're undergoing any type of crisis, and even then responders were qualified to tell the difference between a one type of intervention or first aid interventions from a suicidal risk crisis, that was very important because that allowed us to address a large amount of the population and get to people who would have otherwise not have received the care that they needed. And the fact that this system was built on the existing 911 system also meant that this was within reach of the entire national territory. Person did not need to have a landline or a paid cell phone because in remote areas of the country that are public phones, you can pick up the phone and call 911 for free. This is a service that the entire country is aware of and uses actively. And this is the obvious number to call in the context of a crisis. Also, 911 was indeed getting many calls for suicidal thoughts. Another feature is that emphasis is placed on categorizing cases. This is important because it allowed for some sort of follow-up later on, meaning we were able to pinpoint exactly where the crisis was. And so professionals were able to understand what other interinstitutional and local resources were needed at the time. Another feature is that it classifies or categorizes the situation in the right manners, because there's a difference between a substance abuse crisis or a psychiatric situation crisis or a risk crisis or a suicidal thoughts crisis. Another feature is that we were able to identify through this categorization those cases that were recurring. And we were able to identify those people who would regularly call the landline, the hotline. So that meant that the team managed to devise a separate set of tools and support systems to address that person. Additionally, in this helpline, there was a person, an official from the government, who was the Technical Secretariat for Mental Health. This is a secretariat within the health ministry, and this person was in charge of supervising the entire system. And so this person was responsible for lowering everyone's burnout in the team, addressing the most challenging cases, etc. Because this meant having a specifically appointed person supporting the teams per se. Now, how did we build this timeline? It's a very interesting story. Let me see if I can go over this schedule very quickly. In 2017, the 911 line sent an alert or warned us about a great number of calls that were coming in about suicidal crisis. And so the National Health Board began notifying the government about the need to develop a separate line that would address and tackle these calls. Initially, our mental health hospital, which was formerly known as the National Psychiatric Hospital, stated that they could take over the creation of this line. And so they made available two officials and a small office where they could uh, take these calls. However, there was a limitation. The line would only work during office hours, meaning from 8 to noon, then from 1 to 4 or 5 p.m.
Su jornada laboral. Rápidamente después empieza
Shortly
los
after that,
inicios de la pandemia y se
the
piensa que se
pandemic hit,
necesita otra
and so
para atender
consideration was given to having another line.
Antes de la pandemia,
Actually, before the
911
pandemic,
empieza a identificar
911 started identifying
llamadas.
the
Pandemia,
recurring
esas
calls.
llamadas se
And with the
incrementan.
pandemic, these
Entonces, el
recurring
gobierno
calls
empieza a
became
pensar
even
en abrir
more
una línea
prominent. And
paralela
so
al
attention was given
911,
to the
que era
thought of
el
opening a separate
132.
line.
Ve,
And this one
1322.
was
Y eso era
1322.
para
That was
recibir
the separate
llamadas
line.
de
And this
cuándo
1322
puedo salir de mi
line
casa,
was
cuáles son los
intended for phone
síntomas que
calls like during the
necesito
pandemic,
tener
when can
cuidado
I
en el
leave my
hospital,
home? What symptoms should I
necesito
pay attention to go
capacitarme,
to the
qué tengo que
hospital?
hacer.
What information do
Y
I
el
need if I
gobierno
want to
necesitaba
get training on
sacar
this?
esas
And the
llamadas
government
de
needed
angustia,
to
pero más de angustia
reroute these
administrativo de cómo el país
administrative
estaba manejando
angst
la
calls,
pandemia,
so to speak,
necesitaban
during the
sacarlo de las
pandemic,
llamadas de
and needed
911.
to get
Pues
them
se
out of the
abre
way of the
el
911
1322.
path.
Pero
And
con
so
el
this is the reason why
incremento de la
1322 came into
situación
existence.
de la pandemia,
But when the
las
pandemic
autoridades ven
hit
que
and became
necesitan
larger
una
and
línea
larger,
para recibir
the government realized
llamadas
they
y
needed
hacer
another line
intervención en
to
crisis
receive
y
calls and intervene during crisis
administrar los primeros
and also
auxilios
manage
emocionales.
and
Pues
offer
se
first
comunican con el
emotional
Colegio
aid.
Profesional de Psicólogos
And so there were
y se hace un
conversations
llamado
with
a
the
nivel nacional
Professional
a todos
Association
los
of
psicólogos
Psychologists, and there was
inscritos y
a national
colegiados
call
de
for
ver si ellos
all
podrían de
registered
forma
psychologists
voluntaria
to see if
entrar
they
en
would
una línea que se
voluntarily
llama la
be
línea
part
Aquí
of a
estoy. Hay dos
helpline, which
líneas,
in
línea Aquí
Spanish
estoy
is
del
Aquí
colegio y línea
estoy,
Aquí
I am
estoy,
here.
que es del Ministerio de
And this
Educación,
line
que
is
recibe
under
las
the
llamadas de
Ministry of
menores de edad
Education, and they receive
y
calls from
colegiados.
minors.
Y con estos voluntarios se
And
pudo abrir
through
abrir la
this
línea para
volunteer
dentro de la
work,
línea del Hospital
this
de la Salud
separate
Mental,
line
donde se
was
empezó a
established.
atender las crisis de
And
angustia
so
y
they
filtrar
started
también
addressing and
las
tackling these
situaciones donde
anxiety
había
crisis
un
and also
riesgo
filtering out those situations where there
ideación
would be
suicida o de
some
algún
risk of
comportamiento
suicidal
suicida,
thoughts
de
or
tendencia suicida.
suicidal behavior.
Con el avance de la pandemia,
As the
y la
pandemic
saturación
progressed
en la línea
and
Aquí estoy,
as the
que era en
Aquí
horario
estoy
clausurado,
line
porque de
became
nuevo
more and more
no
collapsed
había
because
fondos,
once again there
todo
was
era en una
a
oficina del Colegio de
time
Psicólogos que se
constraints because
habilitó
everything
y con
happened in an
voluntarios. El
office with
gobierno decide
volunteers
que
who
es
were working
hora
in
y es
specific time
necesario
periods. The
abrir
government
una
decided
línea
it was time
que
to
puede atender
open a separate
las
line
situaciones
that would
emocionales que están
tackle
entrando por
the
un
emotional
911. Y con
situations
eso
that
se
were
abre
being dealt
ya
with via
el
911.
despacho
And
de
so that's
apoyo
where
psicológico,
DAP
de
came on,
nuevo,
this
con voluntarios.
Office
Y en
for
ese momento esos
Psychological
voluntarios
Support.
eran 8
Again,
funcionarios
initially with volunteers.
y
At the
la
time, those
persona
volunteers
que
were 8
venía de
officials
la funcionaria que
and
era
the
parte de
person
Secretaría Técnica. Y
who
por 6
belonged in the
meses
technical
esta
secretariat.
línea
And for
trabajó con
6
esos
months,
voluntarios.
this line
Hasta que
relied on
Costa Rica
volunteer work until
pudo recibir
Costa
un
Rica
financiamiento del
received
Fondo
funding
Mundial. Y con
from
este
the World
recibimiento en
Fund.
septiembre
And
del
with this
2021 de estos
funding in
fondos,
September
el servicio se
2021,
abre
the
a
service
24/7
was
y las
open
personas tienen
24/7.
accesibilidad
And Since then, people can access these 8 professionals any time of the day, month, year, or site. Unfortunately, funding was limited, and in November 2022, the DAP closed down. Uh, it hasn't been ruled out entirely. For the moment, it's on standby, and we hope to find new funds to reopen the service.
So, which was the process? We received a call through the 911. At the time, the operator should identify if the emergency was like a physical emergency, like a stroke, for example, or a heart attack, or if it was related to an emotional situation. Remember, the 911 line, it's exclusive. It's not exclusive for suicide, but at the time that that call was identified as a psychological emergency, it was put through the DIP dispatcher that begins identifying which type of crisis is this person going through. So we use two tools to differentiate between a suicidal crisis or a crisis related to some other situations. One of the instruments is called CASA, C-A-S-A, which is sudden changes, threats, whether verbal or not verbal, feelings, behaviors, and then we have PALIDA, P-A-L-I-D-E, which causes isolation, lethargy, previous attempts, hopelessness, and self-injuries. And as from these instruments, which are quite basically, but that provide important information, these professionals are able to identify which would be the next step, which institutions are to be called, which is the protocol to be followed. So, which are the institutions related to the 911? As it was based in this national system, this allowed us to work in an interdisciplinary manner so that we could cross different resources that we manage at the national level. One of that, it was las different offices, ILAIS and IRAIS, which are each region of Costa Rica has one ILAIS, and each region, according to the number of the population, has 1, 2, or 3 local offices. In these instances, which belong to the Ministry of Health, are born from our national policy, which was passed in 2012, if I'm not wrong. And within these national plans of these national policies, we have a specific point in suicide prevention. Costa Rica decided to a community-based suicide prevention within the national plan. So these offices were the local offices which are interconnected at a national level and at a regional level to help a person and to gather all professionals to support a person with a suicidal crisis. We also have public hospitals that are also included in the first instance of intervention, which are small clinics, which are within public hospitals in case of a risk of imminent suicide, or could also be assisted by a health professional or a mental health professional. So after that, we would need drugs or therapies. And then we have other public institutions that, as of this structure that we have for a DADP, we have a Red Cross, the organizations devoted to children, to the elderly, different types of groups. So, which was the profile of the professionals that work in the DIP? We have psychologists, which were registered at the Registry of Psychologists, and could also be students who work undergoing their master's degree or in a clinical and mental health. They were all volunteers, plus the officer that was provided by the government. And after we got the funds from the World Fund, we had 8 professionals that were paid for their services. A very important part of the work that we performed to build the DIP was the training that this team received. And these are some of the topics in which they were trained to perform their work. For example, pharmacology, anxiety within the COVID-19, intervention in crisis, handling of bodies, grief, post-intervention after a loss due to suicide. These statistics confirm that effectively the way in which Costa Rica decided to create the support line was very important, because between 2020 and 2022, we had in the psychological support, we had almost 20,000 incidents, with 22 incidents a day in 2020, 17 incidents in 2021, and in 2022, 23 incidents. Each intervention lasted approximately 47 minutes, and each case of risk in which we identify suicidal thoughts or a very high risk of perpetrating the suicide was 2 to 4 follow-up calls. The support that the DIP had created a list of codes that allowed the team to have a clear idea to which situation they were facing and which were the tools they had to start managing this person, because the idea was not to remove the thoughts or to make a first aid assistance, but to locate within the community of that person, the different entities and resources at a local level that this person had to continue or to make a follow-up to solve finally this crisis. So we have suicidal thoughts, mental urgencies, suicidal behaviors, and facts against events against the life. Understanding that within this period of emergency in hospitals, we saw about 12,000 people, and out of them, 5,000 were showing a risk of suicidal thoughts, which were pretty high. So the mental health hospitals received also 3,000 people. Which were the strengths of this program to finish? So the immediate assistance for emotional crisis, any crisis, being able to identify the highest risk of a possible suicide. We optimized our public resources. We are a small country. Our resources are very limited. We had an international coverage because through the 911 we could identify all the people that were outside Costa Rica, and we could assist these people through WhatsApp. We could have other offices supporting we generated different resources for the decision-making process, and we could gather information in order to continue with the suicide prevention. So this information was also important to share with the different countries, as we are going to do by the end of the year with Quito in Ecuador. Finally, we received many acknowledgments, international publications at at a national level, that for the work that we did through this period. Thank you very much. Today, I'm presenting this in the name of all my colleagues that made possible this valuable work. And I really wish that we could find the funds to reopen our DAP line, which was so good for our population. Thank you.
Muchísimas gracias, Doctora Seward. Thank you so much. I'll switch back to English, although feel free to answer in whatever language you like. And I think I'm speaking for everyone in attendance and wishing that funding comes back to you as soon as possible. What a great project, and tough that it's on, let's say, on pause. Maybe we can direct the first question then to you, because it relates to that. And I'll just synthesize, because I think we have too many questions to get to all of them. But one of the key sets of questions is really about how to manage in low resource settings. So one question was about Dominica, for example. If you have an island or a small population center, and you're starting a line from scratch, any tips on how to make that effective? Maybe to start with Elizabeth.
Sure, and I'll go back to English so that the Spanglish doesn't start kicking in again. Yes, I really do believe that a great part of our success is that it was constructed within the system of 911, because we had already made 2 attempts to create that system, but it takes a lot of funding to do that. And small countries like ours don't necessarily have all of that funding. So I think the really brilliant idea that came about, and it really came about because of the pandemic. We might not have thought about it if the pandemic hadn't hit us, but we had to be extremely creative. So I really recommend these other countries maybe to think about doing the same thing, because you already have a whole system set up, and you don't have to put money into, communicating. We have another line, go to this line. People automatically think of 911. It's an automatic. Plus, it is a free service, because in our country, Costa Rica is very mountainous, and we have regions, even though we have, satellite communication, if the rain comes in, a storm comes in, a hurricane comes in, you can't call on your cell phone or on your landline, but with 911, there's always a way to get in touch with somebody. So that would be my recommendation. I think that was really what permitted us to do this, and what created this to be more successful than, say, the National Psychiatric Hospital line and the line that we did with the Colegio Psicólogos, which was amazing work, but it wasn't sustainable over a long period of time.
Thank you. Richard or Allison, do you want to weigh in at all?
Well, I would just mention that while we are well-resourced now, particularly for a country as large as the United States, that certainly was not always the case. And so for many years, our system really relied on the sense of mission of volunteers who would man the hotlines and respond to calls. So while we're grateful now to have the funding to be able to hire staff across the network, we would never be where we are today without the willingness of volunteers to answer the lifeline calls. And certainly many of our centers have lots of experience with recruiting volunteers, and volunteers continue to play an important role, but not as central as they were in the past.
And for Canada, I would echo that as well. It's such a volunteer sector, and we've actually tried to retain some of the ethos of that because that brings its own specialness. And you may know some of Brian Michar's research that showed that the outcomes with volunteers were no different than with paid staff. So that's also interesting. The only thing I would wonder about, so I know in Canada, and I think similar to the US, is at 911, there are a lot of like even our handing over to emergency services and the relationship between 988 and 911 is something that's very delicately managed because of issues with trust around policing across the board, but especially in some communities, particularly Black and Indigenous communities. So I think that would be something to manage. And maybe it's, I don't know if you've done anything around that, Elizabeth, like training for 911 or to make it feel more safe to people.
Well, our 911 responders had been trained before the pandemic. I had the opportunity to train them in working with calls where there was suicide risk. So they had already been trained in that. What we wanted to do was not burden them with that. We wanted to permit them to continue focusing, like they would get the call in, they would pick up very quickly because they had already been trained, and they were trained on how to move that call over to somebody who would focus on that part which was more emotional, let's say. So we already had a background work that had already been done. And I think we were able to build upon that. Plus, I think our community truly does trust 911. Maybe that's a bit of a cultural difference that we have from you guys. No, I think our country really, and they tend to call 911 for lots of things, sometimes for too many things, because we have very few hotlines and places because we have so few resources. We have to spread our resources out. It's not a lack of interest. If you look at Costa Rica's history, our public policy in suicide prevention, we started in 2010 working on suicide prevention. I mean, we were right up there in the beginnings of it. The problem is we always have this restraint that our funds are terribly limited because we have a very small population and a big demand. You know, we have public healthcare system, we have public education, many other things. We don't have an army, but all of that money from our army was put basically into our public healthcare system and our education system. And so sometimes, you know, things get run thin. No, the funds run thin.
Thank you. A quick question for Allison and Richard. Is 988 available in any other country other than Canada and the US?
I don't know the number Australia uses. There are three-digit services. So the Netherlands, Australia, come to mind, Belgium. But I don't know about I don't think 988 as the numbers. But it was important for us in Canada. You already took 988, Richard, and US colleagues, to have the same number so that if you across North America.
Yeah, I think one of the things that was helpful was that the United States and Canada shared the same communications infrastructure, right? And while they're separate regulatory agencies, I think that helped for 988 to be in both. England has a 111 system that we actually, before 988, we went to visit because it led to and it's general healthcare. It's all healthcare, although they've recently initiated a specialized mental health component in the United Kingdom, as I understand it. But no, as 988 as the number was, I think, is only in the US and Canada. And in fact, it was many people in mental health in the US had been advocating for 611 to be the number. There were reasons why that didn't happen. And part of the reason that 988 happened, which I think was a very fortunate choice, was because there was no 988 area code in the United States, which would have made it much more complicated to try to shut it down. It was complicated enough because there were maybe 75 communities that had a 988 as their first numbers for within area code dialing, and all of that had to be changed. So anyway, that's what I know about that.
That's really interesting. There's a series of questions about specific groups who call the lines. Maybe I can list a few of them and see who wants to comment. I mean, perhaps Elizabeth wants to say something about, how to handle linguistic and cultural barriers with regards to migrants. And there were questions about Spanish speakers or university students. So, like, how do these lines address different groups?
In the sense that is there a different way of intervening with people because they're a different group? No, I don't think. I mean, obviously, nationwide, yes, there are different ways of working with different. For example, the public universities here, all of them have their protocols for suicide prevention. There was the Línea Aquí Estoy with the Ministry of Education, which was basically solely geared to high school students and to school age students. We have a Women's Health Institute that would also gear to women. But I believe that what we've tried to do is that we have tried to understand, even though that there are differences in gender, in age groups, in different ways that we live our lives, underneath, when you're talking about suicide prevention, there's kind of a commonality there. No, and it's being able to have active listening, being able to ask the correct questions, telling the person that, that they shouldn't feel ashamed, not using certain words. When we construct all of the things that we do in suicide prevention as a nation, we have tried to tell everybody we speak the same language. And then with that base, that educational base, then you can start listening to the differences that people would bring in. Let's say, I'm a migrant, I don't have health care, I'm sick, I have suicidal thoughts. What do I do? Well, let's address, first of all, a little bit the suicidal thoughts. Let's drop it. And then at the same time, they have the whole list of institutions where they know they can send that person once the suicide ideation is down. And then we can deal with how do we get you into the healthcare system, even though you're a migrant.
Allison or Richard, any other comments?
Well, I would add, so I mean, one issue is training, and the other is really being able to communicate. And obviously, this is critical to somebody in their own language or the language that they are most comfortable with. So we've clearly done the most in terms of Spanish language, having that available by phone, chat, and text. Going beyond that has been challenging because while there are numerous other languages spoken in the United States, and we do have an interpreter service that responds to over 200 different languages, which is helpful, but it's not the same as being able to speak to somebody who is to a crisis counselor who is fluent in your language. The challenge for that is having enough people fluent in that language to be able to recruit crisis counselors who can respond in something other than the English or Spanish in the United States.
I think too, like for us so far, what we've found, and we've engaged with over 60 equity seeking populations across the country, and often almost all of them want their own crisis line or they want their own IVR on the crisis line, which would create a barrier. And we've really held off on doing that. And I would agree with what Elizabeth's saying. What we've noticed is it's really awareness of, trust, and access to the crisis line that seems to vary the most across different communities, which we can address in different ways other than changing the crisis line intervention. That once people do connect, but they do want culturally safe services. So they do want responders that they may not know everything about their culture, but that the responder has humility to find out, to collaborate. But I think it's on that access and trust piece that there are differences. And the research will bear it out. We don't have the numbers at this point, but that's my impression so far.
I feel like there's so much more to discuss, but unfortunately, we're just about out of time. I would like to personally thank Elizabeth and Allison and Richard for just amazing talks and a fascinating discussion that I hope we can continue. But now I'm going to turn things over to the Chief of the Mental Health and Substance Use Unit at PAHO, Dr. Renato Oliveira e Souza, for closing remarks. Renato, please.
Thank you very much, Mark. Let me again thank Alison Crawford, Richard McKeon, Elizabeth Seward, and also thank the colleagues that have helped us to organize this second webinar of the series of webinars on suicide prevention being organized by PAHO and the University of Toronto, Amit Tausch, Daniel Sanchez, Natalia Landinis. It has been really excellent to be able to listen to the experiences from Canada, from the US, from Costa Rica. I've been following here the chat, and I see great discussions, participants from many countries in the region, but also people sharing the number of the crisis lines from different countries, which I think it's really a great initiative. Perhaps before concluding, just to emphasize that I think we were able to hear very important experiences from the three countries. It came a lot to my attention, the importance of evaluation and accumulating lessons learned that can be used to develop crisis lines in other countries, but also to improve the crisis lines that already exist. The importance also that the crisis line is not the only service that needs to be available, but it's part of a network of services that can help people in difficult situations. We heard also about the important connection between the work of the crisis line and suicide awareness and the work anti-stigma that we do also at the population level. And one thing that also came to my attention, the way that the countries are systematizing their approaches and standardizing the interventions. So let me thank you once more. Let me thank the colleagues that joined us. At some point, we had almost 600 people joining our webinar, and I think this is a proof of the success of those discussions. I also would like to mention that we at the Pan American Health Organization, we are working very closely with many countries. We receive requests to support countries to develop their crisis lines, and we either support ourselves, but we also connect the countries with specialists in that specific area. Thank you again. I hope you have a great continuation of the week and the weekend, and I'm looking forward to receive all of you again in the next webinar of this series. Thank you so much.
Thank you very much.
Thanks also.
Thank you.
Thank you. Bye.